I want to introduce to you Dr. Jeff Jacobs, tell you a little bit about him. He did his schooling at the University of Mexico. He interned at Duke, and then he did a psych residency and child and adolescent fellowship at the University of Kentucky. And then he joins us here with the COE to share with you about medication with kids with PTSD. So, over to you.
So I'm Jeff Jacobs of Plymouth Pride. It's University of New Mexico. It was the United States. So, feel okay about not University of Mexico. So part of the thinking when we picked this topic was not how dry can we make the title sound. Part of the thinking is that this is an area where people see a wide variation of medication being prescribed, seemingly all over the place. And I would think people in the community, clinicians, almost everyone who's not prescribing it is scratching their head and trying to figure out why is this being prescribed or what is this being prescribed for. And so I hope that this presentation can at least answer that question and give you some useful things to take away. So I may gloss over some of the technical stuff. As I looked at it this morning, I realized some of it would be good if I was giving you an exam at the end of the semester, but probably not the most useful stuff. Okay, so I am just going to dive in here. So, FDA-approved medications for the treatment of PTSD. Do I want to just start calling out the names of them? Just shout out if you got one. Yeah, there are none. There are no FDA-approved medications for pediatric PTSD. So, this is a big part of the explanation of why you're seeing wide variability. Everything prescribed is off-label. There is no on-label. For adults, there are two, and I'll show you those later. The first-line treatment for PTSD has been very well established through good placebo-controlled and waitlist-controlled randomized trials. There's no doubt what the first-line treatment is. Psychotherapy, specifically trauma-focused, and the most robust data is for trauma-focused cognitive behavioral therapy, or TF-CBT, as we always write. That is a well-established, well-proven treatment with lots of evidence. But the second-line treatment for PTSD, if someone isn't responding to therapy, it's 8 weeks later, 10 weeks later, 12 weeks into therapy. Symptoms aren't getting better, function isn't getting better. Then for the second-line treatment, it's actually more psychotherapy. Reevaluate things, maybe move to a different model, seek some supervision to tweak the model. There's a pretty high success rate of doing this, consulting and going a different approach with psychotherapy. Maybe if the first one was individual, move to the traumatized child plus the non-offending parent, something along those lines. Now, let's talk about a typical kid at places where we work and the kind of kids that we often see. So this may be kind of a typical scenario for you. You have a child that you are going to work with in psychotherapy for post-traumatic stress disorder, and they come in and they're prescribed Adderall XR, Zoloft, and hydroxyzine. Their diagnosis is post-traumatic stress disorder. And they're also prescribed Risperdal and Prazosin. And because it's 2019, you cannot get out of the psychiatrist's doctor's office, or sometimes even the pediatrician's office, without being prescribed melatonin. So this might be a not so unusual list that you would see of somebody coming in with post-traumatic stress disorder and maybe one other diagnosis, maybe PTSD and ADHD. And you're looking at this list and you're thinking, okay, that makes sense. What's going on here? And there is reasoning, and I guess a big question is how sound is the reasoning. And often this is what I get as the prescriber. I get a child that got transferred to me on these medicines, and they don't even have a therapist, and they never even had a course of therapy. They're just on 6 medications. Why is that? Why is that? Why do I get a kid on 6 medicines who's never had a course of therapy? Well, it's a source of endless frustration for me. Now, to try to be a tiny bit less hypocritical, I am an adult with high cholesterol. I am overweight. I don't exercise regularly, but I do take Lipitor. So sometimes it might be a little of the kettle. There you go. The cookware calling the other cookware. Why is that? To go over symptom clusters for post-traumatic stress disorder, because I think this will help to give a framework for the reasoning doctors may use for prescribing certain things. And I think one thing to realize is I'm speaking for me. I'm not speaking for the Federation of Child Psychiatrists or anyone but me. I did make this presentation with what I thought a well-trained, competent, and reasonably prudent child psychiatrist would prescribe. And so you're probably seeing kids that are on things that aren't on this list, and with the exception of one that I forgot to put in, and I'll let you know, it's probably because I think it's kind of out there, kind of lacks reason and rationale. So we can break it up into intrusive symptoms such as flashbacks, avoidance of reminders, and avoidance of a lot of other things. In the DSM-5, there is the area of negative cognitions. Still a bit of a shift for me, coming from the DSM-3 to the 3R to the 4 to the 4TR to the 5. To add that 4th one in, and I tend to, whoa, that's not a pointer, that's not a pointer, that's not a pointer. Okay. I still tend to think intrusive symptoms, avoidance, and hyperarousal, but I certainly understand this, why this got teased out. And then hyperarousal, startle response, always on red alert, have to sit in the back of the room and make sure nobody's behind me. Okay, so moving on, hopefully just one slide. So this is kind of, I need one that's more idiot-proof than this pointer. The board is pretty close to the pointer. So I would say the evidence for medication use is about like this. And the medication use in real life for PTSD is about like, more like, that's not quite it. There we go. More like that. The evidence base for if I pull up the randomized controls trials on medication trials for pediatric post-traumatic stress disorder, all of them put together don't quite add up to just the evidence there is for trauma-focused cognitive behavior therapy. It really is, just for one type of psychotherapy, this would be a bigger weight than all of the medication trials for childhood post-traumatic stress disorder put together. Can you all hear me?
Barely.
Yeah, I'm sorry, I'm talking at the screen. It's as if I didn't look at my slides after I made them. All right. I'm not going to start over, sorry, but I will try and talk louder. Okay, so SSRIs are often used most commonly. This is where I forgot a really common one. It's not technically an SSRI, and I think that's why I forgot it, because it's not used as an SSRI, it's trazodone, and it's used as a hypnotic for sleep. So I left that one off, but certainly that's a reasonable treatment that I use myself a lot to help with sleep. I don't use it as an SSRI. The usual dose for depression, so trazodone, as a lot of you may know, it's FDA approved for depression at a dose of 400 to 600 milligrams a day. I wouldn't know if you were depressed or not at that dose because you would be sleeping 23.5 hours every 24 hours. The two that I have in, am I better or a little louder? Is it working? Okay. The two that I put in black, these are the two medications that are approved for adult post-traumatic stress disorder. And so SSRIs by a lot of child and adolescent psychiatrists are considered, if you're going to do a medication, a first-line medication. And our history has been that we're often, the only evidence we have to work with is the evidence from adult trials because nobody's done a trial with the kids. And I could really go on a tangent of why Big Pharma does it that way, but I will not. So we often have to go on that. I put Luvox in gray. It's not that it's a bad medicine. It interacts with a lot of things, in my opinion. And it would be well, I don't actually ever prescribe this to kids because it has such a short half-life and I don't use this. So, to my mind, Celexa, Lexapro, Prozac, and sertraline would be the ones that I would expect to see most often in this class. And so what are we treating here? I think my slides might have gotten a little out of order, but mostly we're treating comorbidities, and that's going to be true of a lot of the medication treatment for PTSD. And so as somebody who prescribes medicine for PTSD, I can tell you that just like every psychiatric evaluation I do, I look for comorbidity because that's a good explanation for why the person didn't get better when the pediatrician took the first crack at treatment. With PTSD, I look almost desperately for comorbidity because now I've moved into a land where I know whether medication treatment is effective, I know which is effective, I know what doses, and I have safety data. And to me, that's a big deal. I want data that shows this is safe in somebody of this age group. And we'll get into kind of an offshoot spin-off of that when we talk about anti-convulsant, anti-epileptic medications in a minute. What time is it, just so I have an idea? 12:24. Okay. This is the part I'm going to skip. Yeah, we're not going to do that. There we go. So comorbid conditions was the next, because I'm skipping this. I was going to talk about there's three specific randomized controlled trials with SSRIs for PTSD. Some brave soul did try to get it approved. They couldn't separate it from placebo. And actually in two of them, it was that they couldn't separate it from trauma-focused cognitive behavioral therapy and placebo compared to trauma-focused cognitive behavioral therapy and the SSRI. Both groups got a lot better, but the group with the SSRI didn't really get more better. I can't believe I'm saying that. Didn't show more improvement. So as I mentioned, this is what we look for a lot of the time with the population I work with. It's almost, I won't say almost a given, I would say 4 out of 5 times they have another diagnosis. Sometimes they are overdiagnosed and they come to me with 5 diagnoses, and when 3 months into treatment with me, they now have 2. But there is typically a comorbid condition in most of the ones that I see. So they're common, and as I mentioned, they can be a guideline to what might make sense to use for PTSD, and specifically what might make sense as sort of a 2-for-1 benefit. So for example, major depressive disorder is very common in PTSD. There are SSRIs approved for major depressive disorder in kids, and also there is evidence to show that SSRIs reduce hyperarousal to some degree, and that they improve negative cognition to some degree. So if I put that in, I know that it's a solid treatment for one important condition, and it is rational for PTSD. So that's why that might be there. If they have another anxiety disorder in addition to PTSD, it's very likely to be there. The evidence for the antidepressants in children is much better for anxiety disorders than it is for depressive disorders, actually. It's clearly a robust, effective, helpful, should still be adjunctive to psychotherapy, but effective treatment for a broad spectrum of anxiety disorders. It is helpful for depression. It's more reliably helpful for anxiety. So I try not to diagnose panic disorder because it really can be part and parcel of the PTSD. However, if they're having panic attacks several a week and they're not going to school because of it, or hanging out with any peers because of it, then I feel good about starting an SSRI, because I feel good that it, along with therapy, that's going to up their percentage chances of getting back into school, because it's going to decrease the frequency of the panic attacks. Maybe in a faster time frame than therapy, where therapy takes the patients that we don't have sometimes, not patients with a CD, not TS. So now I'm going to get into things that have been well studied in adults and children, which is the physiologic changes in PTSD. And this is a large glossing over of stuff that we could have a whole seminar for a year on, but let's not do that. Let's instead say it's adrenergic hyperactivity. This has been well established that both adults and children and adolescents with PTSD all show evidence of adrenergic hyperactivity. So I'm not going to leave you with that. I'm going to explain a little bit what that is. Adrenergic is We also talk about norepinephrine. That's what we're talking about. Adrenaline is another term for it. I didn't put it up, but did I? No, I didn't. Okay. I didn't put it up, but the actual thing they're measuring is cortisol, usually. So if you see something mentioning increased cortisol levels, they're talking about this adrenergic hyperactivity, most likely. Sometimes you'll see H, this is all capital letters, HPA axis. Okay? They're talking about the same thing also. Part of what we get paid for is to make up longer and longer names for the same thing. I'm convinced of that. So that's the hypothalamic pituitary adrenal axis. So all of those terms, think of the same thing, which is their sympathetic nervous system is revved up. And simplified, it's not exactly correct, but it's close enough. They're in a at least yellow alert, if not red alert state, most of their waking life. And they're close to a fight or flight response most of their waking life. They're just this close. It doesn't take much for them to get to that point. And a fight or flight response is exactly the adrenal glands pumping out adrenaline. That is what a fight or flight response is. Or I shouldn't say that is. That is the cause of all the other changes that happen in the body with a fight or flight response. So you will see it go by a lot of different names, but it usually boils down to that they're on red alert and hypervigilant and, you know, what's the term, ready for the tiger or ready for the bear to attack them when people try to talk about it and how did this evolve? How was this adapted at one point? How might this have been helpful? So technically it's not PTSD until day 31. It's acute stress disorder until then. It goes on to PTSD, but if we take, not taking the population that the COE works with necessarily, which is where the trauma was person-to-person trauma, but if we take all trauma, more than half of the people will not go on to PTSD. Now, I'm not saying that applies to the population if you're working with abused and neglected children. That's from all causes. So there's good reasoning to wait out the month. Sometimes there's good reasoning not to wait out the month if they're completely not functional and actively suicidal. So I think it's a great guideline, but shouldn't be used as gospel necessarily. So there have been studies too, since it's not PTSD until day 31, there have been several studies to try to prevent it from happening, which to me seems like a great idea. Let's just not make it happen in the first place. And so we use anti-adrenergic medications. In other words, we use in these trials, and actually we do in the actual world, as you'll see in a minute, there are multiple trials of people using medications that suppress cortisol. They suppress the adrenal gland activity. They bring that stuff down reliably. They bring the sympathetic nervous system down reliably. They reliably have side effects we don't want because they do that. They slow heartbeat. We're not after that, but if you're going to bring somebody's hyperarousal down by this method, that's part of the territory. Also, it's going to cause sleepiness. This is not technical, but it's sometimes useful when I talk with clients. Asleep and severely anxious are almost opposites. It's kind of hard to be both. And so as somebody gets less anxious, it's very, very common that I'm going to induce sleepiness, especially if it's something that makes them less anxious the way Tylenol helps pain. if it makes them less anxious that same day, basically, instead of after taking it for a long time. All right, none of them worked. So none of the trials worked using the adrenergic agents. None of them reduced the incidence of acute stress disorder going on to post-traumatic stress disorder. I realized I should have explained the studies a little better. What they would do is when people would come into the emergency room first identified, they would start the medication right away. A little bit of a biased population, a lot bit of a biased population, but it was the best way to know that there wasn't actually chronic trauma. If we were talking about neglect or abuse, it would be really hard to know if there wasn't undisclosed prior trauma, and you're actually at day 131 and not day 31. So particularly motor vehicle accidents, burn victims, things like that. Unfortunately, it didn't pan out. So what are these anti-adrenergic medications? And so hopefully this will explain another group of medicines that you see prescribed a lot, and maybe help you make a little sense of why they're prescribed. Clonidine, so I kind of flip-flop on this because I put the name people use most commonly in front, which is sometimes the generic name and sometimes the brand name. And whatever's in parentheses is the other one. So I'm trying to go with what you see it by probably most often. But it's always the same medicine. It's just, in this case, these are the brand names, these are the brand names. Actually, for all of these are the generics. Why? Because they're older than dirt. They have been around for 70 years. They're so far out of patent that you probably can't even find the patent in the patent office anymore. The generic's been around so long that that's what they tend to go by. You will still see, I mean, the average practicing psychiatrist is 55, so you'll sometimes still see, mini press. That's probably the one you're most likely, these are the two you'd be most likely to see 10x and intuitive. So if you're gonna try to remember ones, it would be these as a cluster, are all the same medicine. Intuitive is a little different because it's an extended release form. So anti-adrenergic medications, I would say the ones I'm most likely to prescribe would be clonidine and prazosin. And they each work in a little bit of a different way in the brain to suppress adrenergic activity. One can work where the other can't. They're also fairly interchangeable for some causes. So they seem to be particularly helpful for hyperarousal. And that would be where my huge oversimplification of anxiety is the opposite of sleep kind of comes from. Bringing down the hyperarousal is a strength of these medicines, which makes sense because that's what they do. They bring down sympathetic nervous system activity. So we often deal with sleepiness or sedation as a side effect that we don't want. Hopefully, at least every once in a while, blood pressure and pulse are getting monitored because those are both dropped down with these medications. Irritability, angry outbursts, and then possibly the most common way you see them used is insomnia. That would be using a side effect as a therapeutic effect. Really, medicines just have effects. Whether it's a side effect or a therapeutic effect is up to what we want. I have kids who are doing terrific in school on Adderall. We are struggling because they will not gain weight. They need to gain weight and they will not. And it's a huge struggle and it's the worst side effect of the medicine. There were adults, still are some, but at one point it was commonplace in primary practice that an adult got prescribed Adderall for weight loss, for appetite reduction, so they could lose weight. So I like to think of medications as having effects, and it really depends on what we're after, whether it's a good effect or not. So for sleep, they can be helpful. Both of them are out of the bloodstream usually by morning. Prazosin has a reputation for decreasing nightmares more often than trazodone or clonidine. That's a reputation and maybe a loose consensus amongst people who prescribe. I was able to find one solid study that showed decreased nightmares with prazosin, but I was also able to find a few that didn't really show much of that. So you'll sometimes see these, more so the clonidine, prescribed throughout the day, not just at night. And that might be one big reason might be if the person also has ADHD, because that is a really common treatment for ADHD. Guanfacine /10X/Intuitive is very closely related to clonidine, only it doesn't seem to quite pack the benefit for decreasing some of these PTSD symptoms. It is very good for ADHD symptoms. It doesn't seem to be quite as good for PTSD. The trade-off is the clonidine causes a lot more daytime sleepiness. So any of you that have worked with a kid who takes clonidine 3 times a day, more often than not, that's something that is dealt with. And usually what limits the dose. Sometimes blood pressure or pulse does. So clonidine's awesome, but it only lasts about 3 or 4 hours. It's not awesome, I overstated. Clonidine's good in some cases. It only lasts 3 or 4 hours. So it needs to be dosed 3 or 4 times a day. I don't know if your dentist has ever given you penicillin to take 4 times a day, but my dentist gives it to me. I cannot do it. I mean, I feel like it was a victory if I got 3 in. So adherence really, I think, becomes a big issue at that point. I know it becomes a big issue at that point. And you can look at graphs of what % of people take the medications that they're prescribed. Well, let's start right off the bat. Of the medications prescribed, let's pretend we're 10 years ago and I really wrote it out and gave it to you. Of those, 50% are never taken to the pharmacy and turned in. So you can slice 50% off the top of prescribed medications not being taken. Then of the ones taken, once-a-day medicine has decent adherence. We call good adherence taking it 6 out of 7 days. That's what we consider good adherence. And for once a day, that hits around 70 or 75%. So still about 1 out of 4 people aren't managing that. Seems higher in my population, but that's what the statistics tell me. But when you go to twice a day, the rate at which people can take it properly 6 out of 7 days gets cut dramatically to below 50%. When you go to 3 times a day and 4 times a day, it's laughable the amount that somebody can take it correctly 4 times a day. We're talking about in the teens and the single digits percentage-wise. So that is an issue, and especially if the doctor is rushed and not taking enough time to make sure the patient's really taking the medicine. So here's what I'll hear doctors say, because I'm a doctor and I'm a patient, and my kids are patients, and my wife is a patient. You're taking all your meds as prescribed, right? Okay, that's a really common way to say it. Okay, that is such a loaded question. I'm probably going to say yes unless I'm an exceptionally confident person. Is they made it a pass or fail exam for me. They made it, am I a good boy or a bad boy thing. Yeah, I am. And I will get so many patients that I go through their med list one by one, and I try to do that each appointment if I can. And they'll be on that pass list I showed you of 6 psychotropic medications. They're prescribed those. They're taking 2 of them. One of them they may have stopped over 2 years before. And they just let the doctor keep giving them a prescription because they're scared to confront the doctor about the whole thing. Scary, dangerous actually, when you think about it, right? Because the doctor might up the dose. And what if then they get put in a foster placement and now somebody actually starts giving them the medicine they hadn't taken for 2 years? We're going to see some side effects.
I have a question.
Yeah, please.
How do you pronounce that? Clonidine?
What?
Is it clonidine?
Clonidine, yeah.
Okay. You said if they it leaves out of the body in how many hours?
So it's effective usually for 3 to 4 hours.
Okay.
There's still some in the body, but yes.
Okay. That was going to be my question. And how that you already answered that question. But how much does diet and lifestyle, and I'm talking about children now, play into the impact and the benefits of these medications?
That's a terrific question. That's a great question. Certainly diet does. We know that these children are more prone to subtle vitamin deficiencies like a zinc deficiency, magnesium deficiency, things that aren't really tested for very commonly, but they do affect whether medicines work well or not. Vitamin D deficiency has finally hit the spotlight in the past couple of years in people realizing, whoa, this is really important. And I have people that have not responded to their medicine, it hasn't helped them. Then we added vitamin D and got their vitamin D level normal, and now the medicine's working quite well, actually. So certainly diet is important, especially if we suspect a deficiency. There was a large study in New Zealand last year where they treated people for ADHD with a really complicated combination of different vitamins, minerals, and what we might call supplements, things like fish oil and other things. And they have shown it has shown really promising results. And so now I have to wait for it to get repeated, and I have to wait for the United States to recognize it exists. But I'm really excited about this. When I first see a child with ADHD, and PTSD, I'll probably do some of this, but if I first see a child and I diagnose ADHD, I recommend that they start a multivitamin and fish oil right off the bat. And then I check for iron and vitamin D and see where those things are. So it's very important, yeah. Lifestyle can be everything in PTSD. That can be the treatment. I said the primary treatment is psychotherapy. In a way, I glossed over treatment number 0, which is get the child into a safe environment.
Yeah.
That is actually the primary treatment. Get the child out of the dangerous environment and into a safe and nurturing environment. And sometimes that is enough. So lifestyle is huge. There have been some studies showing if you take them camping twice a month or fishing once a week, there's benefit, but they're not randomized controlled studies. They're not the kind of studies that we can use for officially approving things. But as far as physical activity, there seems to be something special about nature compared to just physical activity. So if I take 20 boys about the same age and they're having behavior problems, and at random, I have 10 of them go play basketball for 2 hours, 3 times a week, and I have the other ones take hikes and go fishing. The ones that take hikes and go fishing show more improvement. I'll leave it at that. There would be a lot of theories there. I'm certainly an avid hiker myself, so it wouldn't take a lot to convince me. Yes.
Question. What are your experiences with cafe? In my experience, it doesn't seem to work quite as well as multi-dosing, just
Oh yeah. So CAPVE is the trying to get around the solution to the fact that clonidine only lasts 3 or 4 hours. CAPVE is the newer kid on the block, and it's extended release clonidine. And my experience is that it doesn't seem to release enough at one time to really get there. What's really a drag with medicine is the side effects often outlast the good effects. So clonidine helps them for 3 to 4 hours, but it makes them groggy for 8 hours. That's the sticker for a lot of medicines. An afternoon dose of a stimulant helps their ADHD for 3 hours, but it keeps them up until 1 a.m. A lot of times we struggle with that, with the effect we don't want outlasting the effect we do want. There's some evidence that it helps with intrusive re-experiencing, and like I said, there's definite evidence it helps with nightmares. So those are commonly used medicines, I think, with good reason. And hopefully short term. I mean, by short term, I mean 6 to 12 months. So might not be this, I'm not talking about a course of antibiotics, but a 6 to 12 month thing. Especially if a child is in the foster care system or residential facilities, it's very easy that they're on what I call legacy medications. It was helpful 3 years ago, and it's just not an issue for them now, but nobody's done the trial of taking them off it to see where things are at. Second generation antipsychotics. So these are the big guns. And you will see them prescribed for people with PTSD, or maybe it's PTSD and oppositional defiant disorder, or PTSD and ADHD. What I'm getting at is it's PTSD plus another thing, and neither one of them are things that we would normally prescribe a second generation antipsychotic for. Now this is another, just like I don't like antidepressant, the term antidepressants, I like the term SSRIs, or whatever they do. If they work on norepinephrine also, then SNRI, or dopamine agonist if it's Wellbutrin. I like those terms better because they have such wide uses. I mean, Wellbutrin is the same medicine that helps people quit smoking, that's called Zyban. Exact same medicine. So, second generation antipsychotics, I like to think of them as dopamine and serotonin inhibitors. The vast majority of people who get second generation antipsychotics are not psychotic. The vast majority that get it are not psychotic. And so here we're talking about Abilify, Geodon, Risperdal, Seroquel, and Zyprexa. And these are kind of getting to the age where it's really a toss-up which one you're going to see on the bottle. Certainly, they did focus group studies, the pharmaceutical companies. These are always easier to pronounce and remember. I try to teach patients both. I try to make that part of prescribing. So I say, so how have you been doing with taking the Abilify? It might say aripiprazole on the bottle. How have you been doing as far as how many days a week? So I try to slip that in. So second generation antipsychotics, like I said, we're bringing out the big guns here. We're bringing out the medicine that we use when someone is brought in by the police to a psychiatric hospital to be held against their will to be treated. We're using that's these medicines. That's what these are. We're using the medicine that the person who is so disorganized and has psychosis to such a degree that they can't form a sentence and they can't even talk to you because they're talking to all of the hallucinations the entire time. This is the medicine we use. Or someone that is so manic they haven't slept in 4 days, they spent their entire life savings gambling online and had an extramarital affair and are trying to convince you why they're Jesus and also how they formed a way to make perpetual energy for free. That's these medicines. So we're talking about big league medicines. Here's the rub. They help with a lot of things. They have a really broad spectrum of benefits. And these newer ones, if you look at what's called a receptor profile, which is what are the different things they affect in the brain and the body, it'll look what would be something similar to it. If the receptors are things poking out of it, if they make the molecule, let's say they Abilify like a ball, a sphere, and each different receptor it hits is something poking out of it, I mean, it looks like a big spiky hedgehog. I mean, they affect lots of receptors. And there's a broad spectrum of benefits, and the benefits kick in pretty fast. And the faster the benefits kick in, the more the family believes it's effective, even if that's not the case. So I really try to take numbers down to convince them. I really try to get them to pin down how many panic attacks a week. So I can go back and say, well, 3 months ago you were having 2 panic attacks a day. Now you're having 1 a week. So I think that the Zoloft is helping you. I think it just was a really kind of slow process that you didn't notice. It's not like Tylenol or Adderall. Blam. And they have a broad spectrum of potential problems. And again, medicines have effects. The more good effects it's going to have, the more potential for bad effects. So a way I can immediately tell somebody is trying to con people into getting their money for something that doesn't work is if they claim something can treat a condition effectively most of the time with no chance of side effects. Nope. No. I have to see one before I believe there can be any. It's like the whole black swan thing in philosophy. Like, I haven't seen one yet, so you need to show me one first. Even vitamin D, there is definitely toxicity. It can happen. Low risk, it can happen. Potential problems that you're going to see most often, weight gain is going to be the big one. And sometimes I feel like, and our population's skewed. We're working with just a percentage of the, really the sickest, most impaired children and adolescents who most need help. But it sometimes feels like I'm helping to make a generation overweight and diabetic. It really is a big issue with a lot of these medicines. I have 2 minutes? Holy, okay. All right. Mood stabilizers, so anti-seizure medications. You will see these thrown at post-traumatic stress disorder quite a bit. So these are the mood stabilizers. That there are more, but these are the ones that I think might be reasonable to use. Depakote, lamictal, Neurontin, and trilactol. They can have a pretty broad spectrum of benefits too. They can also do absolutely nothing, and they tend to stick around on their medicine list for years. That really is more of a, it's important to start just that medicine, titrate only that one up while you're not making other changes, and that's how you can figure out if you're getting anything out of them. If they have seizure disorder, then it's a nice 2-for-1 for sure. What do I have here? Yeah, jack of all trades, master of none. They help some with a wide range of symptoms, but they help some. The kid's still violent. They're violent 4 times a week now instead of 7 times a week. But it's still a really big problem, and they're still going to get kicked out of daycare, is what I see often. So potential to provide some degree of benefit in all symptom clusters. Usually you'll see them used as an adjunct. What that means is they're on Zoloft first, and then this is added on. It's pretty rare you see them only on stabilizer. 0 minutes. 1 minute or 0? Yeah, -2. Okay. Lastly, this is the last group, the antihistamines, Benadryl, hydroxyzine, and cyproheptadine. You'll see them written sort of sometimes as needed for anxiety, a lot of times to help with sleep, sometimes on a scheduled basis for anxiety. So antihistamines usually used for anxiety and insomnia. And then, of course, there's melatonin, beneficial for all symptoms as monotherapy. Each tablet contains a full trauma-focused CBT within it, and it makes you smarter. So I will be selling melatonin after the talk. And that's the last slide, which is the review of symptom clusters. So sorry I kept you all late. I apologize. But you've been great.